this is a case of left main bifurcation stenting in a patient who presented with acute onset chest pain, who was diagnosed as NSTEMI, and he had Dextrocardia. So, this was a 50-year-old male patient who was a smoker with recurrent episodes of central chest pain for the last 2 days. Actually, he was discharged from a rural health setup as with a diagnosis of costochondritis. The pain was not getting relieved, so he came to the town and took for expert opinion. So, as we did the ECG, it was quite clear that there was something not normal. So, if we look at it carefully, there was a possibility of dextrocardia, which was confirmed with the chest X-ray, which showed that there was a dextroposition of the heart. And as we did the echo, the ejection fraction was still preserved when we did the first echo, and it confirmed it was a mirror image dextrocardia with the situs inversus. So, the TROP-I was mildly raised, thus making the diagnosis as NSTEMI. So, we decided to take the patient to the cath lab in view of the refractory chest pain. So, with some help of the calcium, we could identify or at least guess the position of the coronary ostia. So, we could engage with a normal Tiger catheter, and we decided to take a few shots with the anatomy to just see the anatomy and rule out any anomalous origin or any abnormal takeoffs. With this, we could see that there was significant disease which actually started from the distal left main, extended into the LAD up to the mid LAD, the long segment disease with maximum stenosis of 80 to 90% at places, and also the LCX, which was a moderate sized vessel, also had some lesion at the ostium. The RCA was relatively good to go. So, then we decided for the ease of our work, we decided to invert the patient position setting from the console by 180 degrees, which actually helped us to take conventional views which we are used to take. So, with this we could take these views. So, we decided not to go for multiple views, a good caudal view and a good cranial view would suffice to make things less complicated. So, these are the views which we decided to go ahead with for the PCI. So, it was decided that.
What view is this right one? Can you tell me?
Which one, sir?
What is the angle on that right view? Just sorry to interrupt.
Okay. So, this was a somewhere between areocaudal and epicaudal. Oh, the right one? Okay. This was.
The right picture.
Yeah, this
what
was.
Is the exact angle that you have taken?
Yeah, so.
Is it RO or LO?
This was slightly with mild RO position, not L.
Go ahead.
So we shifted to femoral route as we had decided to go for a two-stent strategy, as the LCX ostium also showed significant narrowing in the previous views, and it was supplying a fair territory, the SARC. We took a 7 French guiding, and LCX and LAD were wired with 2 run-through extra floppy wires. We decided to first pre-dilate the LAD, and then maybe we would have gone for the IVAS run. So, after we dilated the mid LAD with a 2.5 into 12 NC balloon at higher pressures, there was actually a dissection in the mid LAD, and there was some flow limitation in the distal LAD. So, we decided to go ahead and stent the mid LAD first. So, the mid LAD was stented with a 2.75 into 40 drug-eluting stent at 12 atmospheric pressure. Um, This actually changed our plan a little. So we first decided to go for the stenting after the proper bed preparation, and then we decided to go for the IVAS after we had stented and optimize the result with the IVAS, because the patient was having still some amount of chest pain, and the BP was not that stable. So we decided to put the stents first without wasting much time. So the LCX ostium was dilated with a 2.5 NC scoring balloon at 20 atmospheric pressure. Then the LED ostium was dilated with a 3 into 12 NC balloon at 18 atmospheric pressure, and this showed a fair result in opening up both the ostium and the proximal vessels. Then we decided to go for a nano crush technique, which is our go-to strategy when we are doing two stent bifurcation stenting. So we put a 3 into 12 NC balloon across the ostium of the sarc from LM to LED and inflated it at 12 atmospheric pressure. After we had positioned the sarc stent at the ostium, then with the inflated balloon across the sarc, we usually pull slightly, which ensures that the ostium is well covered, but also prevents the excess protrusion of the side branch stent into the LM. Then we inflate the stent simultaneously with the balloon, and then we pull the stent balloon and go at higher pressure so that the ostium is well flared, and then we do a kissing. After taking out the wire and the stent balloon, we crushed the sarc with a 3 into 12 balloon, NC balloon, which we had kept at higher pressure. And then we stented from left main to LED with a 3.5 into 33 days at 10 atmospheric pressure. Then we did the LM pot with a 4 into 8 millimeter NC balloon, recrossed the sarc, which was not that much of a problem. Then dilated the sarc studs with the same 2.5 balloon which we had taken for the LED dilatation. It could cross without much difficulty. And then after dilating the LED and the sarc with the NC balloons, we did a kissing balloon dilatation at 14 atmospheric pressure. Now we decided to go for the IVAS. So as we can see, there was a good stent expansion and apposition in the mid and proximal LED. In the LMCA, however, though the area was good, but there was some, we can see there could be better apposition. And also in some part of the mid LED needed some higher pressure balloon dilatation. So we took a 3 into 15 NC balloon and went at higher pressures from mid to proximal LED, and did a report of the LM with a 4.5 balloon instead of the 4 millimeter balloon. And this showed that the malapposition which was previously present had been taken care of. This was the final result. The patient improved, was in stable condition for the next 2 days, and could be discharged after 2 days. After 9 months of clinical follow-up, he is doing quite well. So there have been some case reports of dextrocardia presenting as acute coronary syndrome, STEMI in some cases in STEMI, but there is hard to draw any correlation between the two, dextrocardia and coronary artery disease as such, because there has not been large case series to say, because due to the rarity of the condition of dextrocardia. So these are some of the more articles. We know that nanocrush technique is a novel technique for the management of coronary bifurcation. So there was a paper published from our institute. Dr. Shubhanand Ray was the principal investigator. In vitro bench test was done, and also clinical follow-up as well as angiographic follow-up after 1 year showed very good results, which was comparable to the other bifurcation techniques which we have if we compare the data. So we can end by saying that ECG is always not indicative of the extent of the disease or the severity of the disease in STEMI. And the nature of the symptoms and clinical suspicion is always very important. And mirror image dextrocardia, that is dextrocardia with situs inversus, is not so common. Prevalence depends from population to population, and no large case series is there to stamp any correlation with the coronary artery disease. The anomalous origin of the coronary should be ruled out. If the patient is stable, we can also go for CT angiography just to look at the anatomy and the course. The patient, a simple adjustment in the console setting helps in the ease of imaging, and we should search for the best angles for optimal assessment of bifurcation lesions and the disease severity, especially at the ostomy as in our case. So decision for dedicated two-stent approach, as the previous speaker also said, that it depends on the disease severity, tightness of the disease and the extent of the disease and how much area the side branch is supplying. Though provisional approach does the job in most of the cases, in some cases we have to go for two-stent strategies. Nanocrush technique, as I said, offers a simpler yet effective method of two-stent bifurcation technique with the use of much less hardwares and with a budget constraint, we can also do this technique as the hardwares, the balloons required are much less in number. And imaging, as obviously, should be encouraged, especially we are dealing with left main intervention. So, thank you.